So all of the drugs that we use to treat brain pain match up nicely with neurotransmitters that are known to be too high or too low in people with conditions like fibromyalgia. So we are getting to the point now where we are picking our drug and non-drug therapies based on a better understanding of what kind of pain someone has. If your pain is more nociceptive, that far left column from what I was originally showing, then you're going to respond better to non-steroidal anti-inflammatory drugs, opioids, surgery, and injections, because those drug and non-drug therapies are working out in the periphery, in the so-called knee, as I was using as the analogy. Whereas the drugs that are going to work better if your pain is coming from the nerves or coming from the brain are the tricyclic drugs like Flexeril or Elavil, the serotonin norepinephrine reuptake inhibitors like Cymbalta, the gabapentinoids like Lyrica or Neurontin, or the cannabinoids like marijuana. So what I want to do now for about 10 minutes is talk about why non-drug therapies are so important in treating chronic pain, and then give you some guidance about how to use these non-drug therapies. So a lot of the focus in treating chronic pain is in treating the cause of the pain. People can either have a problem in their knee, they can have a problem in their brain with respect to their volume control setting. By the way, I forgot to say this earlier. If you have brain pain, I'll tell you something about yourself that you didn't know was connected to your pain. If you have brain pain, you're also more sensitive to the brightness of lights, the loudness of noises. You have a lot of side effects of drugs, because the areas of the brain that set the volume control setting for how sensitive you are to pain, set the volume control setting for how sensitive you are to all sensory experiences. So again, when you look at a light, if you are a fibromyalgia patient, you couldn't stand up here like I'm standing up here and stare at that bright light without it bothering you. Because that light, you would view that light as being brighter than I view that light. Many of you have probably been cringing because my voice is so loud, but I can't really stop that. It's just the way I talk. Any sensory experience in the human body goes through these brain regions like the insula, and we've shown that, one of the fundamental problems in these conditions like fibromyalgia is the insula is hyperactive, so any sensory information that goes in there comes out to be overinterpreted. Again, someone with fibromyalgia will find lights to be brighter, noises to be louder, odors to be more bothersome, and they'll have a lot of side effects of drugs, not because they're allergic to the drugs, but because they're more sensitive to the drugs the way they're more sensitive to a lot of other types of sensory stimuli. So that's why instead of saying disordered pain processing, this says disordered sensory processing. But going back to this part of the talk, I just want to emphasize how and why these non-drug therapies are working. It doesn't really matter if someone's fundamental problem is in their knee or in their brain. If you've had chronic pain for long periods of time, you develop more stress because of the chronic pain, you become less active because of the chronic pain, you sleep less well because of the chronic pain, you gain weight because you're not as active as you used to be, or you're taking drugs that cause weight gain, or you develop bad habits that you don't know that these habits that you've developed are actually making your pain worse because no one has pointed out to you that this thing that you're doing over and over again is what psychologists would call a maladaptive illness behavior. It's a habit that you developed to survive having chronic pain, but it's a habit that if you keep doing will actually make your pain worse rather than make your pain better. And I'll show you an example of one of these maladaptive illness behaviors or bad habits. But as people have had chronic pain for longer and longer, these things down here start to become a bigger problem than what caused the pain in the first place, because each of these things down here can go back up to the brain and cause your brain pain to be worse and worse, or to cause pain via other mechanisms. And so what we see is that when people have chronic pain for 10, 20, 30 years, even if the volume control setting in the brain is not getting worse over time, or the knee x-ray isn't getting worse over time, these things just get worse and worse over time. And so what people see as they have chronic pain for long periods of time is they slowly, gradually worsen, not because this is getting worse, but because they're accumulating more of these sort of downstream consequences of having chronic pain. These downstream consequences of chronic pain are not going to at all be made better by taking any of the drugs that I talked about or by getting surgery or getting injections. These consequences of having chronic pain we have to attack in and of themselves using a rehab approach and trying to get people sleeping better, trying to get them active again. The body's two most potent internal analgesic systems that are as potent as opioids in the human body for turning down your volume control setting are sleep and activity. We and others have done studies just showing that if you compare people in the population who sleep well to people that don't sleep well, the people that don't sleep well are a lot more pain sensitive. They have a higher volume control setting and have a lot more pain. The people, same with activity or exercise. The more active people are, the lower their volume control setting. And this is why we use exercise or activity as a treatment for chronic pain, because if we can get people active, it doesn't make their pain go away, but we really have to slowly, gradually chip away at some of these downstream consequences of having chronic pain to manage people that have chronic pain, because not all of the chronic pain is occurring from these things up here. And in fact, when I see someone that's had fibromyalgia for 20 years, and in my mind I'm trying to say, how much of this is going to get better by me giving them a drug like Lyrica or Cymbalta that's going to lower their volume control, and how much of this is going to really be more working on a rehab approach that's going to work on some of these downstream consequences. Often, if someone's had chronic pain for 20 years, it's like 70% this and 30% this, that it's really, I'm more aggressively working down here using this rehab approach. And this is where these non-pharmacologic therapies can be incredibly helpful. I'll talk about a website that our group developed called Fibroguide. This is a website that Dave Williams, a faculty member in our group, developed about 10 years or so ago to teach patients with fibromyalgia self-management strategies. We tested this website like you would test a drug. And when we tested this website worked as well as any of the drugs that are approved in fibromyalgia. Now, we're not suggesting you use it instead of the approved drugs. We're suggesting you use it in addition to the approved drug because it's really working in a different way. It's working on a different element of fibromyalgia. It's working down here on a rehab and trying to correct all of these downstream consequences of having chronic pain, whereas Lyrica is working up here by reducing the volume control setting in the person's brain. But you got to use the drug and the non-drug therapies together to get good management overall of chronic pain patients. And this is where resources like Fibroguide can be incredibly helpful, because you can go to Fibroguide and you can spend months in Fibroguide going in the nooks and crannies and the different modules and chapters in Fibroguide, and all of these are aimed directly at patients. So you can try these things, see what works, see what doesn't work, but these non-drug therapies can be extremely helpful in controlling pain and should be used in addition to the right drugs and the right procedures. I'm not saying to use them instead of, but right now in the US, very few physicians treating chronic pain appreciate how important this rehab approach is and how important empowering our patients to help manage their own pain is in overall pain management. So let me give you an example of one bad habit that every chronic pain patient that I've ever met develops. This is what psychologists would call a maladaptive illness behavior. I like chiding my psychologist colleagues. It's like, that's psychobabble. No one can really understand what a maladaptive illness behavior is. So this is, to translate, this is a bad habit that you develop to survive having chronic pain that actually makes your pain worse. So if you go to the website, you'll see me doing the same streaming video, so you'll see it all over again. But what I want to do is give an example of one maladaptive illness behavior. I'm going to draw a graph here to explain this to you. This is one of the occupational hazards of becoming a scientist. You start to draw graphs to explain things to people. I'm actually pretty fun at a cocktail party. I have a good sense of humor, but I might pull out a napkin and draw a graph. So.
Is that a maladaptive thing?
I don't know what it is. It probably is. It's not maladaptive for my career. It's adaptive for my career. It could be maladaptive if I was a total dweeb and I just drew graphs at cocktail parties. Luckily, I'm not. But I think it was that recreational marijuana in the 70s. Yeah. So if you have pain that is coming from your brain, one of the things that you find most annoying about it is you don't know when you're going to have these flares. Because these flares often, like control your entire life. Is that after you start having flares, it's like, well, if I can't do something on a day when I have a flare, then I don't plan to do it at all, because I've had too many times that I couldn't do this thing that I wanted to do because it coincided with one of these flares. So you'll all acknowledge that flares are bad, and that they are probably one of the most bothersome things about having chronic pain, because you don't know when these days are going to occur. So let me, I'm not going to make you guess too long, but I'm going to ask you all to guess what you all do that contributes to these flares of chronic pain. And I'm going to give you a hint so that you can all get the answer right simultaneously, because it'll be on video and it'll be cool that you all get the answer right simultaneously. Is what do you all do after you've had 3 or 4 bad days and you finally have a good day? You've had 3 or 4 bad days in a row and you finally have a good day. What do you all do? You overdo it. You try to get everything done that you weren't able to get done those last 3 or 4 days. This is the reason I love this for the audience participation part of the program, because everyone gets the answer right. What does overdoing it cause? What do you do again 3 or 4 days later when you feel good again? Okay, so this is what psychologists would call a maladaptive illness behavior. It's not, it's something that you developed. It's a habit that you developed because you got stuff you got to get done. You got to survive. You have things you want to get done, and if you feel good, it's sort of intuitive that you might want to actually then do something proactive and get stuff done. But this unknowingly contributes to the flares. And so if you had this maladaptive illness behavior, this isn't by any means the only maladaptive illness behavior that people develop. It's the one that I use as an example. There are 2 modules in Fibroguide that we would have you go to. The first module in Fibroguide that we have you go to is called pacing. And pacing sounds simple, but it literally is teaching people that if you do about the same amount of activity every day, whether you're having a good day or a bad day, you can turn this pattern of flares into something more like this. And if I gave you a drug that made you go from green to black, I'd declare a success and keep you on the drug, because it's making your flares about half as often as they used to be, and it's reducing your peak pain by about 30%. It's not a home run, but it's a single or a double, and that's all we're hitting is singles or doubles when we're treating pain. By the way, if you know baseball, there's not a lot of home runs in the pain field. In fact, if you try to hit home runs, you'll strike out in the pain field. That's the problem in the pain field. But so if people pace, they on average, over a couple months of doing homework and really trying to change their behaviors, they can change their pattern of pain from this to this. No side effects, no cost, no nothing, except just a self-realization and an understanding that you were in some way contributing to these flares, and that you can, at some level, you're not going to make the flares go away. There's going to be some natural variation of flares, but you're at least not doing this to contribute to this. And thus, you have less flares, and they're not as intense when you have them. So this is the first thing we would have people do, is do the pacing. They'd get better. The second thing we would have them do is something that we encourage people to do after any treatment that is effective, whether it's a drug, whether it's a procedure, or whatever, and that is start doing things that you now can do because your pain is better, that you weren't able to do a month ago or a year ago when your pain was worse. So let's imagine that you really used to like to go to the movies with friends. That was like your really thing that you really enjoyed doing. And it turned out that because too many movie dates that you planned coincided with flares, either you stopped planning to go to the movies with your friends, or your friends stopped calling you because they didn't want to keep getting dissed every time. But for one reason or another, you stopped doing this because there were too many times that it coincided with a flare. Well, that was all very reasonable, because at that time you couldn't do this. But now that you're in the black line rather than the green line, you can do it. The flares are less often, the flares are less intense. So pick the last thing you stopped doing, or the second from last thing you stopped doing, because that was something that you stopped doing just when you went over, your pain got a little worse, the frequency of your flares got a little worse, and that put you over that hill where you couldn't do that thing. Well, that's the first thing you should start doing again. And this sounds overly simplistic, but the module that does this is called Pleasant Activity Scheduling. And it makes people with chronic pain understand and appreciate that their biggest responsibility in the overall management of their chronic pain as a patient is that when your pain gets 20% better or 30% better for whatever reason, a new drug, a procedure, it just happens, there's no reason, your responsibility as a patient is to try to improve your function by 30%, is to try to go back up to doing the things you used to do when your pain wasn't as bad. And then what happens is you'll actually spiral upward. This is really one of the really cool things about taking care of chronic pain patients when you integrate this rehab approach with the drug and the non-drug therapies, is that people with chronic pain will almost always slowly, gradually get worse, because what happens is the pain leads to decrease in sleep, increase in stress, increase in weight, decrease in activity, which leads to more pain, and people slowly, gradually spiral downhill. Year after year, they get 5% worse, 20% to 10% worse. But in many cases, the fundamental cause of the pain hasn't changed at all. It's that these downstream consequences of the pain are causing this slow, gradual worsening. And these are the things that we're taking on. So when someone as a pain patient appreciates this and they get a 20% improvement in their pain, and it's like, okay, when I'm gonna do this is go to this and start going to movies with friends. Pleasant activity scheduling, there's two types of categories that chronic pain patients stop doing when they get chronic pain. These are things that are so the things you stop doing as your pain gets worse and worse are things that are fun and things that keep you active, and sometimes they're things that are fun that keep you active. But these are the things that are on this list in pleasant activity scheduling. We don't know which of those 50 things on the list are the things you want to do. It's just a bunch of random things that people like doing, but we do make you start doing them and say, because you got this improvement, if you capitalize on that 20% or 30% improvement in your pain by starting to do stuff that you had stopped doing, you can actually spiral upward, because you'll sleep better at night because you're more active, your symptoms will get better. And this is really the essence of this rehab approach in integrating the non-pharmacologic therapies with the pharmacologic therapies, is that these really work well together and complement each other. And I don't think we're ever going to get to the point that we're going to be able to treat chronic pain without using these non-pharmacologic therapies and without, at least in part, employing this rehab approach. Even if we get blockbuster drugs that are really a lot more effective at treating chronic pain than we have right now, I think we're always going to have to be integrating these non-drug therapies with the drug therapies. And the problem with these non-drug therapies, they're not widely recommended by the people that are seeing you. They're often not really reimbursed by third-party payers, or they're not very available. This is why Fibroguide can be very helpful, because this is all something you can do on your own via a website. You don't really have to have any specific, anyone prescribing it or anyone specifically recommending it.